and Inclusive Growth Institute is. It's probably something that not everyone is familiar with. I've put our mission statement up here, which you can choose whether you would like to read through or not. But at the core of it, we have a mission to conduct and promote research that will then contribute to those mission areas in our name. And we do that in two ways, really. The first is by growing the connections that the Federal Reserve has to frontier researchers who are doing work in areas related to our mission, just like Krista. We have folks coming every year, connecting us to really the most current research in a wide variety of topics that can connect to our mission, to make sure that it really understands those just as well as we understand things kind of more central to a central bank, like macroeconomics and exchange rates and things like that. And then the second thing we do is try to share the results and implications of that research more widely. And that's what we're excited to do today. So I'm going to talk about 3 projects, and Krista and I are actually going to tag team and go back and forth. So hopefully that will keep things moving, but I know we have a lot of material to get through. So please put questions in the chat if they come up, and we'll be excited to leave time and get to those towards the end. So I'm going to start off talking about our work, our joint work on workplace COVID symptom screening. Then Krista's going to talk about recent work she's been doing, looking at nursing facilities and nursing homes and COVID deaths. And then I'm going to come back on and talk a bit about a project on mental health disparities that I did with another one of our researchers at the Institute. So I think workplace COVID symptom screening is probably very familiar to many. Perhaps even some in the audience have had a hand in designing information like the one that I put up here, which is from Maine. These are screens that I think many of us now experience if we are to go in person to our workplaces. It is actually required of some or all employers in 34 states. And by that in particular, that means beyond places where COVID might most actively be transmitted. So early in the pandemic, it was become commonplace for nursing facilities and hospitals and healthcare settings to screen. But now in 34 states, that goes well beyond that, and employers are receiving instructions to screen really broadly across a wide set of industries. This is recommended by OSHA, and workers in surveys report that these screens make them feel safer at work. So it seems to be something that, at least for now, is popular with workers. It seems likely that this type of screening is going to remain for a variety of reasons that you can see listed here. And we think it's worth noting in particular that should there be future outbreaks of other communicable diseases, this practice of regularly screening individuals is now so common that it seems likely to resume were we to face another outbreak like the one we're experiencing right now. Given that this has rolled out so rapidly to such a very large set of Americans, there really are a lot of important questions to answer about how these screens work. And so we're going to focus in the research we're going to tell you about today on a bit more descriptive evidence to help us have some context for how these screens might work. So in particular, it's helpful to know how common are COVID symptoms. This is separate from how common is COVID because, of course, the symptom checkers in many cases are not able to follow up with an actual medical test. So it's important to understand when we think about how screens work is just how are people likely to answer these questions about symptoms, which may or may not connect very closely to the actual presence of disease. Who in particular are these symptom checkers going to screen out? And is this different for different groups of people? We're going to be able to examine that with the data that we'll share in a minute. And then finally, are there underlying health reasons that might differ across groups or survey response behaviors that might differ across groups that would lead screens to disproportionately flag certain individuals from different groups versus others? So I want to highlight that this project is really the first evidence on these questions. It is descriptive, and we were just talking before the seminar got started that I think this is an area that's really ripe for some experimentation and some good study design to try to understand the broader impacts of these screens. and really to get at a question that we in particular can't answer today, unfortunately, which is, do these screens work to reduce the transmission of disease? Our data are not going to have information on the presence of COVID as an infection. And so what we can only answer is really what's likely to happen with the screens, and not so much what the screens do to the level of COVID in the environment. So I cannot go through these all right now, but we can make the slides available if you would like. All I want to emphasize with this is that there actually are a variety of COVID area survey sources. We are going to be working with the first one, which I'll tell you about in a second, but also we'll be drawing on information from the Census Household Pulse Survey. I hope everyone here is getting familiar with that. If you haven't seen it already, I highly encourage folks to check out that source. So just in the spirit of making some of this information more available, there really are a variety of survey sources where you can do interesting things on symptoms and even COVID diagnosis in some of the survey sets already. So I just want to suggest with this graph, and this gives you the title and location of our actual paper on this, that there's reason to think that COVID symptoms are keeping many workers home. This is ideally something I think that we would like to encourage. We want workers who have COVID symptoms to stay home and get evaluated. And just a really rough piece of evidence on that comes from the Census Household Pulse data. That's what's in this graph. Weeks 11 and 12 are in July. And then kind of prior to that every week covers June and May. And you can see that by summer, worker absenteeism suggests that about a third of workers who were out for COVID symptoms. And that suggests potentially an increase over what firms might have been experiencing before. So this is something we're going to explore in more detail with information from the COVID Impact Survey. In particular, the COVID Impact Survey is something that I co-directed. We were able to roll that out and field it in April and May of 2020. So this is information from earlier in the pandemic, all the way up through the first week in June. And we're focusing on a national sample. There also are geographic subsamples in that survey data set as well. But the national sample comes from a standing subject panel called AmeriSpeaks. And from this survey, we're going to be able to construct 7 approximate screens. We have individuals, about half of the individuals in our survey are asked, are you able to take your temperature right now? And about half of them say yes, and they take a temperature and they report it. So we have a thermometer-based screen for about half the sample. We also ask self-reported symptom questions, very much like those on that checker that I put up at the beginning, or that you might experience going into work. Folks are asked about fever symptoms, a variety of those over the past 7 days. They are asked this in 2 ways. There is a long symptom checklist asked early in the survey that has many symptoms on it. I believe it's about 19, but 3 of those are fever-related symptoms. And then there's a short fever-only symptom screen asked later in the survey as well. And so from those, we can construct indicators for whether you had fever symptoms, both from the long and the short checklist. We can also construct a kind of more stringent screen, which is that did you have 2 or more of those fever symptoms? And then we do the same basically for COVID symptoms, which is a broader constellation of symptoms on that longer symptom checklist. We don't have a short COVID specific checklist in this survey. And that long checklist allows us to identify the 7 CDC main symptoms on that checklist. And again, we can create an indicator for whether you had any symptoms or whether you had 2 or more symptoms. And I'm going to hand it over to Krista now to talk us through the findings and then to pivot to work on nursing home outbreaks.
Great, thanks so much, Abby. So first we examine how many workers report each of these symptoms and how many workers would be screened out under each of the 7 symptoms. And so what we see is that really across these screens, a lot of workers would be screened out. So this ranges from about 5% for a high fever, all the way up to more than 50% in a given week for a single COVID symptom. Next slide. And in general, we see that the screens that require multiple symptoms for a positive result are going to screen out fewer workers. We also see that because workers screen out, or because each worker is going to report a particular symptom, screens that require a longer list of symptoms are also going to screen out more workers. So for example, we see more positive results on the long fever checklist than we do on the short fever checklist. Next. We also then can see to what extent are these screens going to be internally consistent or similar to one another. And so what this table shows is in each row, conditional on reporting, say, a positive high temperature, what's then the likelihood that you would also be screened out under the short fever checklist or under the long fever checklist? And what we see is that with the exception of the diagonals and then the ones that are going to be won by construction, where it's a subset of the longer list, all of these numbers are going to be below 1, which suggests that fewer than 100% of workers who are screened out under one screen are going to be screened out under another. So then we can do a little bit more of a deep dive and say which types of workers are different types of screens going to screen out. So this table, again, is showing on the right-hand side various screens where we have an indicator for 1 if you're screened out. And then on the left-hand side, we're including a whole bunch of demographic characteristics to see what's most predictive of having a positive screen. And we see that across the screens, there is some variation in the types of workers who would be screened out. But in general, we find that younger workers, women, and non-Hispanic white workers are going to be more likely to screen positive across a lot of these screens, even after accounting for their likely COVID exposure. And so this suggests that there's the potential for these workplace screens to result in disparate impacts just because of the way that different groups are going to be reporting their symptoms. Next slide. We also do the same type of analysis, but then say to what extent is getting a positive screen correlated with underlying health status or exposure to COVID. And here we see that households that have a known COVID diagnosis, again, early in the pandemic, or know someone who has died from COVID, are at high risk for severe infection or report being in poor to fair health, also are more likely to screen positive. And these patterns suggest that although screens are imperfect, they do capture some useful information about exposure to COVID or likely risk. So just to recap, we find that across screens, workplace screens are likely going to screen out many workers on any particular day. And we estimate that across the 7 screens that we're examining, our screens will screen positive between 0.4 to 7% of workers on any particular day. And this is particularly important for employers when you're thinking through that the likelihood of having your workforce reduced by 7% on any day could really affect how they're making decisions. We also find that details in the different screening methods matter. So there's going to be higher positive rates on screens that come from a longer list of symptoms or require fewer affirmative symptoms for a positive screen. So say you just need to check 1 symptom versus 2 or 3. We also find that the survey design, the number, and the types of symptoms are going to screen out different individuals, and that these group differences in reporting may lead to disparate impacts. And then in the paper, we go through the importance of encouraging truthful reporting. So we want these screens to be accurate, and we want employees to truthfully report whether or not they're experiencing a symptom. And so there's a couple of ways that we might go about doing this. One is by encouraging paid sick leave so that workers reporting a paid or a positive symptom don't incur an income loss. Another way is to tie the responses or the ability of a particular worker to go to work based on like a group average response. So it's more indicative about kind of the overall or broader exposure to COVID. So kind of pivoting to a completely different topic, I want to share some early evidence on what we know about COVID deaths in nursing homes and features and characteristics of nursing homes that are predictive of this exposure. So this isn't news to anyone in the room, but both in the US and in Minnesota, nursing homes have experienced a disproportionate share of COVID-related deaths. Next. And the number of facilities with any COVID death has only increased as the pandemic has gone on. So even in May, more than 20% of facilities had reported a death due to COVID, but this has continued throughout the pandemic with more and more facilities having an infection resulting in a death, so that by the end of December, more than 75% of facilities had a death amongst the residents. And so we can see, so to what extent is the likelihood of having a COVID-related death, is this related to underlying characteristics of the facility, and how have these patterns changed as the pandemic has gone on? So on the left panel, the indicator, the x-axis is showing an indicator for whether a facility has its first death early in the pandemic in May to June. And on the right is showing whether the facility had its first death later into the fall months. And then we can see the extent to which deaths in nursing homes are going to be correlated with various metrics of nursing home quality. So in general, things are pointing in the direction that we would expect. So for example, facilities with a lower overall rating, lower health inspection rating are going to be more likely to have a death, as are facilities that have lower staff to patient ratios, those that have more fines and violations, and those that have a higher occupancy rate. And in general, these patterns haven't really changed that much as the pandemic has drawn on. Next slide. But importantly, and this might have been foreshadowed a bit just given the prevalence of COVID in nursing home settings, that even amongst the highest facilities, a substantial share have experienced a death amongst the residents. And so these two plots are showing, again, on the left-hand side, the distribution of a facility's 2019 CMS star rating, so a measure of kind of the overall quality of a facility. And then the share of facilities that have had no deaths in each star bucket, had an early death in the middle red bar, or were able to avoid a death until the fall months in the green bars. And what we see is that even amongst the highest rated facilities, there's a substantial share of facilities that have incurred a death. This is similar when we're looking at overall ratings as well as the health ratings. So these patterns suggest a couple of things. First, it could be that the metrics that CMS uses to measure overall quality aren't capturing all of the information that is relevant to a pandemic type of infection spread. And then just given the patterns that we see over time where the late deaths look to be increasingly common in the higher star facilities, it suggests that just the longer nature of the pandemic has kind of worn away some of the ability to do a short-term response. And so this is really preliminary descriptive suggestive work. There's some interesting work showing that one factor that's contributing to the spread of COVID in nursing homes is staff who are working perhaps in multiple facilities, and so might have exposure in one and then go to work in another. So in forthcoming work, we're looking at the daily staffing data to examine how different types of state level policies and access to PPE and other types of measures can help slow this spread. So stay tuned for more.
Thanks, Krista. And so we wanted to give you a snapshot of just one final piece of work. For this, I'm going to take us back to the survey data that we were working with earlier. I think this is giving you a good sense of how economists at least are working with different sources over the course of the pandemic to try to understand various questions. Our screening work is really dependent on really good surveying ability. The work on nursing homes and deaths is dependent on really high quality administrative data that's shared from facilities up through other sources. So I think it gives you a kind of snapshot of how economists are approaching this. I will say one thing we've left out that you won't get to see today is some creative ways that folks have used big data. There's definitely some work that's gone on with folks using cell phone tracking. That's been a major source of information for economists and for others in the pandemic. And some of our institute folks have worked with that as well. So we're happy to talk about just the variety of sources too in the Q&A session. So looking at mental health disparities, I worked on this project earlier this year to try to understand where the disparities of the pandemic were widening and where they were happening. And one dimension we chose to focus on was mental health. So the economic impacts and disparities of the pandemic became readily evident, I would say very early on. And what we knew a little bit less about is how this is working for people from a broader well-being perspective. And getting that perspective was really a big part of working on the COVID impact survey. And it's exciting that that has carried through into the census's approach as well, trying to take a broader view of how folks are doing that includes measures around mental health and other measures that might indicate a general level of financial or economic security, in addition to kind of our very standard questions about employment and earnings and hours of work. So in this project, we focused on mental health measures that are available in the COVID impact survey. Very similar measures are also available in the Census Household Pulse Survey in an ongoing way as well. And we really wanted to ask two questions in this project. The first is, how did mental health change across places and groups in the US in the pandemic? And what you see on the right is a piece of analysis that really looks at that group specific question. What we found overall is that the change in mental health was really broadly shared across the United States. And we didn't see very pronounced differences in that that seemed very different from what we might experience in kind of overall regional differences in mental health. So for us, really, this story was about how was this impacting different groups. What you see in the dots and the red line are indicators for whether a group's mental health reporting differs from their incidence of poor mental health reported prior to the pandemic. In this case, in a different survey, the Behavioral Risk Factor Surveillance Survey, folks here may be somewhat familiar with that. They ask a very similar set of questions that we're able to harmonize, let's say it that way, and make comparable in the kind of pandemic era as compared to the pre-pandemic era in the BRFS survey. So what we find is that in the pandemic era, first of all, there was a marked increase in poor mental health incidents. That's that top dot that's way off to the right. These are indicators for whether you had any poor mental health days in the last 7 days. And you can see that in the pandemic era, that's the COVID impact survey indicator, that level of poor mental health was elevated by over 20 percentage points above that pre-pandemic level for the typical person responding to the survey. So this was a really large shift in the overall level of poor mental health. Then what you see going down is whether that shift was different for different groups of people. And what we find is that many of these indicators really don't have statistical significance that's different from that baseline effect. So what that's telling us is that any mental health disparities that existed prior to the pandemic have largely shifted so that everyone is worse off in the pandemic, but they're not worse off relative to other groups to a very great degree. And we think that's informative for thinking about just the overall impact of the pandemic. I do think some of these results are surprising for folks. So in particular, we find a worsening of mental health relative to other groups for Hispanic individuals and also for higher earning and more educated individuals, but not a relative worsening for individuals who identify as Black or other groups like women that we've heard a lot about in the media as well. So again, what this says is that there are mental health disparities, but that many of them have persisted through the pandemic. And it's only a few dimensions where that relative disparity has actually worsened or changed. And we want to kind of emphasize that in particular, we also have a way in these data sources to look at how we might compare some of these mental health impacts to what folks are experiencing in terms of other, what we would call pandemic events. So I think this gives us a way to get a grasp on the scale of these mental health changes in a way that's kind of unique to the pandemic. So the way we do that is we actually run a regression. Again, on the left-hand side is just that variable, did you experience a poor mental health event in the last 7 days? And we then ask whether other types of pandemic experiences affect the likelihood that you had that poor mental health event. And you can see results here, both from the census data, the household pulse survey, and the COVID impact survey. And you can see that the COVID impact survey allows us to look at a number of items beyond what were available in the household pulse survey. The pulse survey is now adding some of these as we go into 2021. So it will be really important to be able to validate some of this, see if it's changed, and then keep track of this in a much larger national statistical survey sample. But what we found using these data, which go through July, is that pandemic era income loss and food insecurity worsen are associated with a poor mental health incident. And those effects are large. Remember, I showed you the shift in mental health baseline was about a 20 percentage point increase in the incidence of poor mental health. Income loss and food insecurity are associated with poor mental health almost to that same magnitude, about half of that in the case of income loss and almost the same in the case of food insecurity. That changes a little bit as we go from survey to survey, but broadly, those two things are worsening mental health, which I think we would expect, of course. People who are experiencing a change in their economic security and their economic and financial well-being in the course of the pandemic, that would seem likely to induce stress and a variety of other poor mental health states. We see that, in fact, that is happening. On the other hand, we can also compare this to other COVID experiences. And in particular, we have indicators in the COVID impact survey for whether folks have had a diagnosis of COVID in their home for themselves or for someone else in their household, whether someone has died of COVID who is in their circle of close friends or family members, and also those same symptom measures that we saw at the beginning of the talk. What we see is that when we look at these COVID experiences alongside the economic experiences, for the most part, economic insecurity, particularly food insecurity, continues to be a strong predictor of poor mental health. But also, these COVID experiences are really negative for mental health and for reported incidents of poor mental health. In particular, having a COVID diagnosis in your home, that's at that top of that kind of middle box, and having any COVID symptoms in the last 7 days, that's that bottom small box. Those are associated with poor mental health changes that are about as negative as the income loss change and the food insecurity change that we saw in the household pulse survey. So our takeaway from that is that, in fact, some of the disparities in mental health around COVID are very much related to specific experiences that folks are having either in the labor market and economically, or with COVID or COVID symptoms in their own households. Those might not necessarily map as expected to those group differences that we saw in the previous slide. So I want to wrap up with a few of the highlights for policy from each of these projects and then open it up to questions. So hopefully folks have them. Please put them in the chat. I love questions and we are happy to answer them. So in terms of thinking about what policymakers should take away from this, like Krista emphasized, the symptom checkers could screen out up to 7% of workers in the US per day. That's a large number. That comes from converting those bars that Krista showed to daily rates. It could be smaller. It could be on the order of a little bit under 1% to somewhere in the middle. But nevertheless, as we saw with the Household Pulse survey, that's a large fraction of worker absenteeism already. And potentially we're talking about increasing worker absenteeism by that measure by up to maybe 30%. So this could be a really significant change for US employers. Nevertheless, it's important for them to figure out ways to accommodate that. And in particular, they need to think about two things. One is kind of how to use the screens that are available to them. We know that from our work that broader screens are going to correlate with demographics and narrower screens are going to miss or kind of turn up fewer positive cases. So there may be kind of a trade-off between casting a wider net on symptoms, but then potentially generating disparate impacts. And so one of our big takeaways in the paper is that employers need to think about this balance, perhaps in partnership with community health officials, and they need to be watching their incidence of positive screens to see first, are disparate impacts happening, and also, are they actually screening folks out? Because our survey suggests that folks should be reporting these symptoms at some rate, and if they have a workforce where no one's reporting them, potentially that indicates that workers don't feel free to report those symptoms. Policymakers also need to think about ways, perhaps in conjunction with employers, to support time away from work for individuals to get their symptoms evaluated and to self-isolate if they need to do that. And again, I will kind of close that out with a plea for more research into understanding what makes this self-screening effective. Do we need to encourage folks who report at lower rates than others to report more? And what is the community level impact of these screens? We really don't know the answers to any of that. And nevertheless, we've rolled this out to really almost the entire US workforce in a short order. So I think a bit of well-designed research and careful studies could really answer a number of these important questions pretty quickly. In terms of nursing facilities and prediction of COVID deaths, we think it's important that we take away from this that low staff ratios and high occupancy rates are factors predicting these COVID deaths. So there are patterns that we can see in the data. On the other hand, these patterns seem pretty persistent and they don't seem that linked to overall health ratings for these facilities in a way that I think we might have expected from the rationale for setting up those rating systems. So I think this suggests that either the quality measures that we have are incomplete on this dimension, or potentially the long-term nature of the pandemic is just presenting risks that even the highest quality facilities are not able to successfully contain. And finally, in terms of what policymakers should take from disparities in mental health and our analysis around that during the COVID era, I think it's important, first of all, that policymakers are just aware of how much mental health has worsened in the pandemic. There are gaps in this, but they're relatively unchanged compared to the pre-pandemic gaps. So I think one thing to take away from this is rather than focusing on specific groups who might have had a very accentuated mental health impact in the pandemic, it's important for policymakers to know this is really broad and very large. Also, it's important to know that COVID itself is contributing to this through economic vulnerability specifically, and also through experiences of COVID deaths and symptoms. So folks who've had COVID in their household are definitely experiencing a bigger downturn in mental health than others, and understanding whether they recover from that or the longer term impacts, I think are important. And finally, I would hope that policymakers would start to consider the immediate consequences. I know we hear a lot about this, but I think having a kind of wider appreciation and thinking about policy tools that could be rolled out right now to counter the immediate consequences of these changes in mental health are important. Those include violence and suicide. But also policymakers will start to need to think about the long run consequences, particularly for children's outcomes, as there's evidence that children in households where parents and adults are experiencing poor mental health have long run outcomes that are affected by that. So starting to think through that kind of trajectory of what are the really long run impacts of the pandemic going to be, I think mental health is an important place for policymakers to start with that. So thank you, and we're happy to take questions if folks have them.
Thank you so much. My mind is just like going a mile a minute thinking about everything and all the connections between all of these. What you said were very different topics, but everything is so connected. We have had a few questions in the chat that I've made note of. There's a couple questions related to the workplace screenings. Maybe I'll start with those. So one question was, did the COVID symptoms include loss of taste and smell? And was additional screening done to remove those with known cancer, et cetera, where fever might be part of their treatment?
So we did have loss of taste or smell on the long symptom checklist. We did not do additional screening on cancer in particular, I don't think. That one I would need to double check. We had a number of underlying conditions that we did screen on. And so we didn't actually remove those folks. We did remove folks who were not in the labor force. So we were focused on workplace screening and what employers might expect. And so making that restriction was important. So to the extent that these are folks who are not working actively because their illness is that severe, we would have had them out of the sample. But they might have been in the sample. Yeah.
Thank you. Another question related to the screenings. Has there been any information or research looking into folks who lie or maybe misrepresent their situation on screenings? And what are the implications for workplace spread or community spread in general?
Yeah, so this is one reason we think it's so important to try to start doing projects that look at how this happens in practice. We think a big advantage of our approach is that this was an anonymous survey taken at home. We think that folks had very little incentive to misreport their symptoms. I think we're also reassured that some of what we find on symptoms lines up with symptom reporting in other settings. For example, it's perhaps somewhat surprising, but particularly on the mental health dimension, there's a known race and ethnicity gradient in that. We see that repeated in our data, even though the levels are different because of the pandemic era. So I think our view is that people are reporting on these symptom checkers in our survey the way they do in other studies. And that is unconstrained by their ability to go to work. So I think what we're getting is a snapshot of the symptoms that people have. But that might not be what employers get when they ask people, especially if folks are concerned that there'll be consequences for them, either for not going to work for a day, or perhaps even in terms of separating from their employer. So we really emphasize that it's important for workers, for employers, and broader, I think, federal policy really to have levers in it that encourage workers to report honestly. That give them paid support if they have to miss work to isolate, and that we have some means for making sure that workers are not fired or otherwise have negative employment consequences for doing this reporting. I think some of the policy we've had has worked to do that. There have been extensions of paid leave in some of the federal packages. I think we don't have a good handle on how much that has actually reached into every firm and every establishment. And so doing those projects, I think, would be really helpful.
Yeah. So anyone on here that's looking for a big, important project to do, I think we're getting some good suggestions. With nursing homes, there was a question about if this study is ongoing, a one-time study. Are there plans to make it more longitudinal?
Yeah, I think there are definitely plans to make it longitudinal. CMS, to their credit, has done a really good job at providing weekly updates. on both the availability of various PPE, masks, gloves, gowns, as well as the number of cases, testing, deaths that are occurring in each facility for the entire country. So there's a lot of really rich data that that we can use to explore other dimensions of this.
Thank you. There was also a question related to the nursing home data. Is that Minnesota specific or national multi-state data?
Yeah, so the data I presented today are going to be national, so for the entire country. There is the geographic identifier, so one could also do it for a particular state or a subset of facilities as well.
Thank you. One question just came in related to the mental health research that you shared. Was there screening for additional influences, such as a current or lifetime mental health diagnosis, the political climate, other things like that?
Yeah, so we did not ask anything about the political climate. We did have one of the weeks of the COVID impact survey, and I think this is true of the Understanding America study as well, which is on that slide. They have a similar format where they have what's called a standing subject pool, people who they are recruited into the sample to take the survey or other surveys regularly. So both of those surveys had response weeks that fell over the major protests at the end of May after the murder of George Floyd. And so some of them, I think, are useful for trying to look for how mental health has changed around those events in the context of the pandemic. Layering those things together seems very complicated. It wasn't something we tried to do in this project. But we otherwise didn't ask about political kind of events or attitudes. I think some of that might be in the Understanding America study. You won't find that in the federal sources. So that's not something, there's a specific restriction against federal sources using statistical agencies to do what's defined as polling. And I think that makes sense. But as a result, they don't often ask about political attitude type questions. But Understanding America study is run out of University of Southern California, and so they ask a broader set of questions. It is possible in our data to screen on a lifetime mental health diagnosis, I think just for depression, but it is not something we screened out in the mental health study that we did. We were interested in really looking at these whole population level impacts of switching into the pandemic era as compared to the pre-pandemic sources. And we didn't actually look at whether this had differentially affected folks who had a pre-existing diagnosis, but I think that would be a really good question.
Another question related to the workplace screenings is if other symptoms weren't included, does that mean that they weren't statistically significant?
Krista, do you want to take that one, or I'm happy to?
Yeah, sure. So the work that we presented today, the screens kind of compiled a bunch of different symptoms. And so for COVID, for example, that would include loss of taste or smell. In additional work, we did look at the likelihood of reporting each symptom individually. And what we saw is that the fraction of recipients that were going to be screened out positive, a certain fraction reported any particular symptom. So for example, like some workers always reported loss of taste or smell, some reported like fever or chills. And so it wasn't the case like COVID reported diagnosis was just being driven by everyone saying that they had experienced a loss of taste.
Yeah, I always describe that result as it turns out lots of people will report any given symptom, is at least on the list of 19 or so symptoms that we had. We really couldn't find any that just nobody reported. And it's interesting because folks, when we started presenting this, would say, well, why don't you look at something that's like very unusual, like loss of taste or smell? And you actually have about 14% of the sample reporting that. So that could happen for any number of reasons. They certainly don't all have COVID. That's what makes it a screen, and it's a noisy signal of underlying infection. But it does mean that anything that you ask about, people probably will report. So that's part of that reason for that finding, that if you keep adding on symptoms, you will screen out more and more people. You're just picking up other things that people report.
Mm-hmm. I frequently feel like I have a runny nose, for example.
Yeah, another one was like, are there sets of symptoms that aren't associated with COVID that we could look at? And then our reading, at least, and we'd be interested if folks think this is different, but our reading was that there really almost aren't symptoms that are not associated with COVID. There's a very, very broad constellation of symptoms that could be connected with it. So we didn't have a good way to pull out things that were definitely not COVID. We did emphasize the 7 main symptoms that the CDC emphasizes, but it was hard to point to anything that we would say, well, that definitely couldn't have happened with COVID.
Mm-hmm. Could you speak a little bit more to the BRFSS data, and if you were able to get that at a 6-month point, as it's usually provided 1 year at a time?
Yeah, it is not available at a 6-month point. I don't know if everyone else does this, but in economics, we call it the BRFS. So I don't know how everyone else handles that acronym.
I wasn't sure, so I just.
Yeah, so yes, that would be great. My understanding is there are no plans to do that. I don't even know. I'd be curious if someone does know. I don't even know if they're planning to add questions on COVID to the next year's BRFS. I just don't know. So it's great in the mental health case that we could use it for pre-pandemic measures. But I think I'm really hoping that they will be adding a module or something on that to at least get the year snapshot. But yeah, it would have been really valuable to have an intermediate data point.
Mm-hmm. Kathy has commented that there's a lot of discussion about that right now. Mm-hmm. Yeah. I'm wondering, the Minnesota Public Health Association, one of the things that we want to do is really think about how can we like learn and collaborate across sectors. So I'm wondering if you could share a little bit about how you think public health could like use the resources from the Federal Reserve or from you. How can we connect more with economists and economic researchers to really like enrich and improve our work?
Yeah, and Krista, I'm interested if you have stuff to add on too. I think, so first, I think events like this are great. I think it's incredibly valuable for the Federal Reserve to be out talking about the research that we do. And I'm excited to be part of the Institute because I think we are a unique place for researchers, like I mentioned at the beginning, outside of that kind of more typical kind of subfields of economics to connect with us. So we have an interdisciplinary advisory board. Some of you may know Tim Beebe. He is actually just joined our advisory board. So we're building some connections to the U and public health through him as well. But yeah, I think we're always interested to hear about research and opportunities. So I think folks should feel encouraged to reach out. That I think one of the big takeaways from this is how can we work better across fields? We've had a lot of interesting conversations in economics around that. And I hope that folks will want to continue to work together going forward.
Mm-hmm. I would encourage everyone to explore the Federal Reserve's website. There's a lot of stuff related to COVID, a lot of great stuff, I think, related to impacts on parents. So explore all you want. I'm going to share my screen real quick as we close out. Thank you so much, Abby and Krista. There's been a lot in the comments. thanking you for this information that is interesting, that's useful. I echo all of that. It's been really wonderful, and I've been really excited about having this conversation and hosting you all. I want to highlight for everyone a couple upcoming events the Public Health Association is doing. This Friday, as in 2 days from now, we have a member coffee break. So if you're interested in learning more about what MPHA is up to, connecting with people, learning how to get more involved, I encourage you to attend that coffee break. The information is on our website. Our policy forum, our next upcoming one, is March 5th, and it's about environmental justice, particularly focused on vulnerable populations and how the burden of economic disparities and injustice hits particular communities in ways that cause disparities. On March 17th, we're going to have a member-only event with Dr. Ed Ellinger, where we're going to talk about the public health perspective on pandemics and plagues, thinking about how our society is changed by all of these events. And our annual conference is April 29th and 30th, and that theme is Bold and Humble, Engaging in Anti-Racist Public Health. That registration should be opening soon. We encourage everyone to connect with us, stay engaged. The MPHA website is here. Follow us on Facebook, Instagram, Twitter, LinkedIn. If you have any questions about anything, you can reach me and the folks at membership at the membership email, or our executive director, Mary Grand, at the admin@mpha.net email. We will be sharing this recording out with everybody. There was a question about if you'd share your slides, Abby and Krista. Okay, I will follow up with you about that then. Thank you so much, everybody. Thank you, Abby and Krista. This was wonderful. I hope you all have a good rest of your week and really hang in there as we continue to ride out this pandemic. Thank you.